Hello and welcome to Module 3 of the Bigg Elimination Tribute Project, Building Provider Capacity for Hepatitis C Prevention Program Integration. Module 3 will focus on vaccination. Again, my name is Jill Wolfe. I am the Hepatitis C Program Director with the Caring Ambassadors Program. And this program was co-created with the Chicago Recovery Alliance and adapted from a training we did together in October of 2019. We thank you and are grateful to our sponsors for support in the training. As the title of the program indicates, this project is in honor of Dan Bigg, former Executive Director of the Chicago Recovery Alliance and a good friend of the Caring Ambassadors Program. It's with his spirit that we developed this training and bring it to you today. The overall project goal of the Bigg Elimination Tribute Project is to build the capacity, confidence, and knowledge for you to integrate responsive Hep C screening, testing, linkage to care and cure, and support programs into your existing infrastructures. As we've talked about, this training is divided up into 7 modules. We are currently in vaccination. Module 4 will start with staging, treatment, cure, and we will end with wellness and support. The purpose of this module is to orient you to the role of hepatitis A and B vaccination practices, especially in the care of people living with hepatitis C. By the time this module is complete, you will be able to utilize the tools received to monitor your vaccination program as a part of the services that you offer for people living with hepatitis C or at risk for hepatitis A and B. And you will be able to integrate the supplemental resources for ongoing support. There's a few formalities that I think are important for you to think about as you stand up or integrate a vaccination program. I'm going to first say that I consulted the IAC, or the Immunization Action Coalition, as I developed these slides, and I highly encourage you to check them out for their comprehensive vaccine support information, their wealth of handouts and tools available. So if you just watched Module 2, you remember we talked about physician standing orders that are necessary for hepatitis C testing. And as we talked about, a PSO enables other healthcare professionals within the system to function at their fullest capacity by conducting approved and often these uncomplicated clinical services to help aid in developing relationship and certainly saving time and resources for that system. As it relates to vaccination, the necessary physician standing orders that you would need are a PSO for the administration of hepatitis A and B vaccines, and also the managing of the adverse reactions for those who might develop them after a vaccine administration. So those physician standing orders are different and both will need to be on hand. And ultimately, the management, each of these will say that, let's say that you vaccinate someone and they have poor outcomes. There's a step-by-step guide on that PSO of what you would do to manage any adverse reactions. With the administration of the hepatitis A and B vaccine PSO, this would indicate any scheduling and certainly the criteria for someone who would be eligible for a PSO. IAC has a toolkit that I highly encourage you to check out, especially as it relates to the storage of your vaccinations, the supplies that you might need, physician standing order templates, the scheduling of the PSO, how you can allow for quality assurance, and the actual administration of the vaccinations. There's a few options as it relates to hepatitis A and B vaccinations. In this case, there's 3. You have a hepatitis A vaccine, you have a hepatitis B vaccine, and then you have an A and B vaccine known as Twinrix. When I worked within an addiction treatment facility, this was the one that we used because our population was at risk for both A and B, and it was helpful in being able to maximize the resources and the minimal resources that we had for a program that was not funded through grants. So something that is vital to understand before we go ahead and vaccinate someone specifically for B, we need to understand, has this person been previously exposed to these viruses? We need to know if they actually have active infection, and we need to know if they've already been vaccinated. And to give a real life example, I have colleagues who work with immigrant populations, and there's a large issue when individuals immigrate into the United States. There's a process by which we medically examine people. And part of the challenge in terms of resources and misinformation is that oftentimes those who are coming and immigrating into our country will be vaccinated for hepatitis B, but not tested for hepatitis B. And this is a huge problem because hepatitis B is incredibly infectious. And so individuals are given a vaccine and told that they are now immune and that they are protected, when actually there are many people who have chronic infection before the vaccination is even provided. And if you are chronically infected with hepatitis B and receive the hepatitis B vaccine, that vaccine has been wasted on you and is a waste of resources because it will not provide immunity because you have this chronic infection. So again, before providing, and this is more specific to hepatitis B than it is for hepatitis A, but do they actually need the vaccine? Have they been previously exposed? Do they have this active infection? And that's specific with Hep B. And have they already received it, such that we wouldn't inoculate them? In order to actually test, for hepatitis A, what you would test for is the total Hep A antibody. This would be the IgG or the IgM. Again, antibodies simply determine if you've been exposed. And so if this test was negative, you would then, it meant that that person has not been exposed to hepatitis A and do not have antibodies, and therefore you should provide the hepatitis A vaccine. For hepatitis B, we have two tests that would be needed. We'll start with the second one here, this hepatitis B surface antibody. Again, testing for antibodies to determine if someone's been exposed. If the person is positive, if this surface antibody is positive, it means one of two things. Either this person's already been vaccinated or they've been exposed and they've cleared the virus. We don't know which one it is. If this is negative, we would want to provide that vaccine for that person so they would be protected. Now again, taking this antibody further, this just shows exposure. It doesn't show if they have active infection. So the Hep B surface antigen determines if you have that chronic infection. If the antibody is positive, we would move on to the antigen. And if this is positive, it likely means that that person has hepatitis B. A few things to follow up here and to keep in mind as you consider integrating vaccination into your programs. What is your process to access people who actually need the vaccination? And how are you able to follow up with those folks? In this case, working with people who use drugs, what is the way in which you're able to build rapport, provide enough information on the importance of this vaccination such that you're able to maintain contact and ensure that they receive the full schedule of the vaccination? Who within your program has the skills, like a nurse, to actually be able to provide that inoculation or vaccination to your constituents? How will you actually get the vaccinations in hand? I know that there are many departments of health throughout the country that have small grants or small allotments of vaccines, and they're able to distribute these to community programs such as yours. And so possibly you'd be able to actually get that resource from that health department and provide this to your constituents. However, again, how are you going to follow up with that patient to ensure this completion of the full schedule? That brings in the question of which schedule is best for you and your program that you serve. We're going to go into this in just a second on the next slide. Want to make sure we talk about cost of testing and reimbursement. If you are lucky enough to have a health department that's able to give you for free or in kind some of the vaccine, you're not actually able to get reimbursed for the cost of that vaccine. However, if you were able to provide that vaccine for that person, you could bill for the administration and be able to get reimbursed on administration. The last piece is ensuring, and this is difficult because there are not many vaccination programs that are funded, but what is the additional cost or cost that you work into your program to determine the testing for someone to identify if they actually need the vaccination or not? We don't want to waste the precious resources of vaccinations, but we want to be sure that the vaccine is getting into the bodies of those who need it. So this is information. I encourage you to look on the Hep B Foundation, which is a link we've provided on the resource page. But you'll be able to get the Hep B schedule. And there's 3 different types of schedule. We've got the 3-dose schedule, a 2-dose schedule, which actually was only offered in the US, and this 4-dose accelerated schedule. Now, typically we're using the 3-dose schedule, at which point we give the first administration of the first vaccine at any given time, or if you're a newborn, and especially if you were born to a Hep B positive mother, we would want to vaccinate you within 24 hours of birth. For that second inoculation, it needs to be at least, and that is a minimum of 28 days after that first inoculation. And anytime you see at least bolded and underlined, that means minimum. And so that third vaccination needs to be a minimum of 16 weeks after the first inoculation, or at least 2 months after the second. And so you might go, say, for the second inoculation, you may go 60 days, and that's just fine. You just need to make sure that the minimum window is met for each of these dosing schedules. For the US only, there is an approved dosing schedule of a first shot at any given time and the second shot at least 28 days after the first. Didn't really actually, sorry about that. I didn't see a ton about the rationale behind this, but I do want to speak a little bit about this 4-dose schedule, which is an accelerated schedule that's generally not recommended for people, but it is appropriate for those who need to get something, a vaccination complete within a certain, by a certain period of time. And so the 4 doses are needed to achieve this full long-lasting immunity. And this accelerated schedule was something we considered for folks who were living in our program at an addiction treatment facility on a short-term basis, and they would only be there for, say, a month, but that we had a program whereby we could follow up with them. And so for those cases, there were some situations where we would give that first inoculation at any time, that second inoculation 7 days after that first, the third inoculation between 21 and 30 days after the first, and then a year later after that first inoculation, we would follow up with them. And this, while it did require an extra dose, for some people this was more appropriate given their living situation or their situation that might have been with the courts to allow for certain treatment and allowing for the most immunity coverage to happen. Let's talk a little bit about what's changed in terms of hepatitis A and B and certainly C. We know across the country we've seen liver cancer increase, a lot of which is directly related to underdiagnosed, undiagnosed, or late diagnosed hepatitis B and C. And the other thing that we're seeing that's changed are the state-reported hepatitis A outbreaks. As of May of 9th of this year, that's just a couple days ago, this is this map, a heat map of the state-reported Hep A outbreaks. And you'll see the darkest states are those with the largest number of outbreaks. The white states did not report, and the lightest blue are the states with the least. The gray are states like California that have declared their outbreak over. And I do want to reference back in Module 1A when we talked about syndemics. We talked about using hepatitis A and access to, vaccination in California being a really great example of how access and homelessness and harm reduction might play together to, in this case, potentially have quelled an outbreak such as this. So This is the main thing that's changed that I want to point out. And finally, I do want to point out a couple of resources for you, again, both of which will be on Module 3 landing page on our Caring Ambassadors Bigg Elimination Should Be Project website. But I want to encourage you to look at the Hep B Foundation, really great for Hep B specific information, especially as it relates to that inoculation schedule. And then the IAC Immunization Action Coalition has been a really great resource, and I actually took a snapshot here. I want to point you to the handout and staff materials and the clinic tools, both of which are drop downs, and you'll be able to find templates for those physician standing orders that we talked about, and even handouts for your clients as you start to inoculate. So in conclusion, you have completed Module 3, vaccination. We'll be moving on to Module 4, which is staging. And the purpose of Module 4 is to illustrate the process and the timeline associated with staging people living with Hep C. I want to encourage you to complete your pre and post tests to get your certificates or your CEs. And of course, as always, access our individual module pages for the resources and our larger program page for any other resources. And you can always reach out to us with questions should you have any. Thank you, and we'll see you in Module 4.